somewhere in the world, someone is getting their foot amputated because of a diabetic ulcer related to peripheral artery disease, one of the most debilitating diseases that still most have never heard of, yet impacts 1 in 20 Americans over the age of 50, 1 in 3 diabetics over the age of 50. One of the most common complications of diabetes is a vascular issue such as peripheral artery disease, and that leads to diabetic ulcers or non-healing ulcers on the foot because of restricted blood flow. Doctors around the world are trying to figure out, how do we prevent these ulcers? How do we get these patients in sooner to check their feet, to monitor their feet, to actually be able to know that an ulcer is developing before it breaks through the skin? Well, innovators are answering the call. We have quite a few companies that are emerging right now with different types of imaging technology. We have Podimetrics, which is offering a remote mat and service where they have people helping to monitor patients. The patient steps on the mat. It senses whether or not a patient is having some issues with the feet and they should be seen. There are video and other camera technologies, and one of those is actually Revealix. And we have Adrianna Cantu. She is the founder and CEO of Revealix. She is also a board certified wound specialist and former physical therapist. Thank you so much for being here and helping us to look at this landscape and better understand it.
Kim, thank you for asking me to be a part of this. I'm really excited about the work that you do. And I think that's a perfect setup for what really has helped me to bring this company forward.
And what was the catalyst? When did you first discover that this was an issue that wasn't being addressed in an appropriate manner and more needed to be done?
Yeah, no, so the impetus really comes back to, my background. I am a clinician, board certified as a wound care specialist. And, my entire professional career has actually been in wound care. While I'm a physical therapist, I would ask that most people, I understand what's going on, but unless you have a wound, I'm probably not the right person for you. So my early career started in the trauma center, in which case we served. I'm here in Austin, Texas, and we served a multi-diverse population, several counties. Many were under-resourced. And I think in that environment, I saw very quickly what was happening with the diabetic limb. It was an incredibly devastating impact when you can see, the evidence, you understand what to do, but you saw people coming in so late. You saw people coming in very unaware of how vulnerable they were. And then you saw them not have the resources or the network in place to keep them well. So, I saw that day in and day out, and I know that my story is the same as every other wound clinician or nurse who's actually working in this population. So that was my, front and center hands-on view of this problem. From there, I went into what was a startup. I guess at that point, I didn't realize it was. I followed a lot of my friends, and in that role, I spent 10 years as an executive in the industry and really building out our operational and clinical infrastructure to drive the company forward. But that's when you saw from the operational and executive level the devastating impact that consistent wounds have across healthcare. And so it's really been my passion is to not only be an expert in treating wounds, but now, honestly, it's all about preventing wounds. I know that I've really become very ingrained in what the clinical best practices are. And the challenge has been, we know what we should be doing. We have been challenged to actually implement that into everyday care. And Revealix is really, for me, trying to dismantle what exists today and take the first principles approach and really just kind of go at it and say, what is the job to be done? The job to be done is to identify the at-risk foot. That's job number one. And so that's what the evidence says to do. It's what the practice guidelines say to do. And that's what Revealix is here to help do in a mobile platform.
It seems really obvious that you don't want to wait until the skin breaks before you would address a diabetic ulcer. can you paint the cost picture of that? I mean, the cost of prevention versus actually having these wounds, which once you have them, especially when you have circulation issues, how quickly they can turn and literally spin out of control and not only cost, you know, life and limb, but also cost systems greatly financially.
My goodness, that is probably one of what really alarms me when you think about all my time and all the time that we're all spending on healing wounds. There's some tremendous work being done, but when you pull way back, 80% of our time and effort and healthcare dollars around, you know, lower limb complications is spent after the wound has occurred. So we are spending so much energy, time, and resources trying to save patients' limbs and lives after the wound is there. The opportunity is to actually refocus all of our effort, most of our effort, on the pre-wound side of care. And that's really where Revealix is focused. We are absolutely really bringing to life what the evidence says can prevent up to 80% of diabetic foot wounds. And the first thing is to, you know, anybody that's looking at the diabetic foot, what you're doing is you're trying to pick up on risk. We know what could happen. We need to be able to pick up on all the different systems of change. Is there, you know, neurological change? Is there vascular change happening? Is there musculoskeletal change happening? Is there skin or, you know, nail change happening? Is there something about the shoe? All of this is risk. So a physician, a nurse, you know, foot health specialist, they're all there to help the patient to evaluate, is there some change in risk? With Revealix, that's really what we want to help automate to capture that in an objective way. We're specifically focused initially on the temperature changes that are clinically meaningful to any skin assessment. And so we are focusing that initially on the diabetic foot because it is so preventable when you have that heads up.
What is available now for clinicians to use if they say, hey, patient, take off your socks, I want to check your foot? Is there anything, if the skin hasn't broken, if there isn't sort of something visual, is there anything in these clinics right now that doctors, if they so choose, can use in order to know if a diabetic ulcer is on its way?
There are a number of options. If you kind of think about, well, if you're looking for temperature changes and you can now objectively capture that, you know, what are the different options? And one of them, I think you mentioned earlier, was Podometrics, and they've been really one of the initial, they've done a lot of great work. And it's a temperature sensing mat. So there's different sensors placed on the mat. That tends to be more for, I know that they are in clinics, potentially in the VA, but most of these are for at-home care. So that's one option. So the patient would have to step on the mat and there are sensors to read that. Other options, and probably the gold standard was a TempStat at that time, MR3, but it's a stick that has a sensor on the end. So you've got to touch different points and it's digitally reading it. That's another option. There's other options that have sensors embedded into socks, sensors embedded into insoles. And so those are different options. They tend to be more applicable to patients that have already had moderate or high risk for complications. They probably already had a wound. And so they're appropriate and they're really best suited for at-home monitoring. And Revealix is in the same position. We're able to do that at-home monitoring. Where we've differentiated ourselves, and how I've thought about it, is the idea to make sure that we are a non-contact solution. So that allows for someone to just quickly be able to take, you know, in a few seconds, an image of the patient's feet, and within 30 seconds, you're getting a real-time display of the objective patterns. It's a thermal mapping, so you're getting an augmented reality display of the temperatures that matter on the patient's feet. What we've learned is how helpful that has been to the patient-physician experience. So in the clinic, we really have seen this become such an important part of how they are able to explain, you know, what is the risk? What are we seeing? Well, how does this impact the care plan? And certainly that now is a very helpful part of their documentation.
But other than these devices, such as yours and others, and in Podimetrics, let's say, in the clinic, and yes, they are limited right now, and they're doing a lot of their studies with the VA. And is there a really effective way that these doctors can see if something's forming already, or is it just a guessing game? When they go in, they kind of feel the foot, but it's mostly visual, right? Like, hey, take off my socks, look at my feet. It's really tough to tell in that moment, okay, well, maybe one foot's colder than the other, or one area is colder than the other, but just by physical touch with your fingers, I would think that would be very difficult to be accurate.
It is, Kim. So going back to what's not available technologically, what we have are our hands, and that ability to put your hands on the patient, and what you're doing is trying to discern temperature patterns that are different. You know, we should be symmetrical right to left, unless disease or pathology is starting to take hold. In the diabetic limb, that's particularly meaningful. It is not sensitive enough, and frankly, it's not even done enough. So what we're thinking about is, how do you remove the barriers to getting that information about temperature changes in the foot, so that you can bring that into your assessment. And so that is the critical thing, is to build awareness, but then make it easier for that to be done. And one of the things that I particularly like is because it's an objective capture, the way that we've come up about this problem is that the medical assistant can do it, and the physician can then read that. And I think that's also helps with the clinical workflow.
And this is something that I would think should be marketed to the gatekeepers of health, the primary care physicians, and also endocrinologists, the ones who regularly see
Yes.
the diabetes patients. But you have some states, like in Mississippi, where you may only have one endocrinologist. So it falls back on the primary care physician, our gatekeepers or general practitioners, to do some of this preventive testing. I mean, but so many of them won't even take a blood pressure cuff off the wall and measure, for the pulses, right? So it's like, how do you expect them to use a device like this on a regular basis, especially when it comes to diabetic patients and those who have been diagnosed as well with peripheral artery disease? How do you?
Well, that has been the conundrum, because the primary care is just, they have a tremendous responsibility. There they are on the front lines as the gatekeeper, as you said, and so someone with diabetes is a complex patient. There's probably another comorbidity there as well, if not more. And at the same time, when you have a patient who is diabetic, the way that we see it, and the way the American Diabetes Association recommends, and they have escalated their recommendations. So patients should also always get at least one, the comprehensive exam. So we know that. What has also been recommended is that every time someone with diabetes shows up at their healthcare visit, that they get the foot inspected. So that is something that I think it was in 2019 where that changed. Maybe it was 2018, but that is an escalation, and it really gives us the emphasis of just how important it is to look at the feet. Now, when we think about someone with diabetes, the reality is looking at their foot is the vital sign for that limb, and the ability to do that in a very expedited way, in an objective way. That's a lot of the thought. When I say dismantle, start over, what do we need to do to make this a little bit easier to adopt, a little bit easier to communicate throughout the care pathway, a little bit easier to scale? The one thing that needs to be done, and it's that diabetic foot check, and to capture risk. So it's why we've had conversations with primary care, like, hey, we love it. Can the medical assistant do it? Can our nurse do it? And then I can walk in the room as they do their other vitals. So I sort of see that that's really where it could happen if you can create a repeatable foot check.
Where do you find the resistance? Because you've gone out there, you've talked to these primary care physicians, you've talked to other clinicians. What resistance do you face in terms of their willingness to use a device such as this to more effectively and accurately check these diabetic patients and their vitals?
Yeah, so a lot of it is probably what any new technology on the market has to overcome, and that's the status quo. The status quo is hard to overcome because these are very busy physicians and clinicians, and they have worked very hard at their existing way of caring for patients. So anything that you do that adds to that, it has to deliver ROI. It has to deliver an impact very quickly. And so one of the things that we've done is really build out the entire clinical workflow. So while we have a very novel and innovative solution that does fit into that particular point of care moment, the entire software system, and we're Diabetic Foot Health as a service. So when we come at this problem, it is about the entire problem, end-to-end solution. And what that means is that anybody that is participating in the Revealix program has the ability to basically drive the evidence-based recommendation for protocols for the diabetic foot, starting with a validated diabetic foot check, so that one, you understand what is the risk profile of my patient, what is the risk profile, the risk factors for each foot, what should be the appropriate care pathway. Should they continue in the primary care environment? Should they get referred to a podiatrist or another foot specialist? And the patient as well can become a part of that journey. As I mentioned before, now that they see their imaging, their engagement has really escalated to the point of them asking, like, hey, can I see Revealix? How am I doing? What do I need to do differently to help that red spot go away? So this is just the beginning, but it's really been the inspiration for why, I left my role to start this company, knowing the evidence, knowing really a huge gaps that still need to be closed. I feel like, we're on that journey with the patients as well.
You want to show us how it works?
Well, what I can show you is, let me pull this up. Essentially,
it's interesting when it comes to, as you're pulling that up, that we may need higher policy changes in order to make this a part of the workflow, because a lot of these primary care physicians have standard protocols for their 15-minute or 30-minute exams, depending on whether it's just a basic follow-up or whether it's an annual exam. And it needs to be part of their checklist. So in order for it to be part of the checklist, you need to go up to the higher up, the administrators of these healthcare systems, in order to get those standard protocols changed. So you need to convince them of the financial savings. You mentioned ROI, and it's sad that that's true. I mean, who wouldn't want to prevent anyone, even one person, from getting one of those diabetic ulcers, which are incredibly painful and tough to heal and could literally lead to amputation? As I said, every 20 seconds, someone with a diabetic ulcer is getting their foot amputated. That's a lot. So I think that that's where we need things to happen first, is really at that higher level. Unless you have independent primary care facilities or independent private primary care physicians that don't have standard protocols dictated to them by a larger healthcare organization.
No, I totally agree. And one of the things that we're finding is, who are the early adopters and the innovators in this space? And it really comes down to who is already looking at the diabetic limb and understands, the clinical information. Podiatrists, wound care physicians, vascular physicians, they very well understand. And they're actually really good with technology too. So they're ready to kind of pull that in. So for us, it's about demonstrating that, how easily we can adapt to their existing workflows. It adds another 30 seconds, and the value they get has been worth it. So what I'll show you is, the idea is that you can take a camera. This is one of our models, but this is an off-the-shelf camera that is we can plug it into your smartphone, whether it's your iPhone or an iPad. The physicians are typically using this already in their clinical environments. What the software does is really, you aim it at the patient's feet. So there's a little image off to the side here, and I think on my screen, and the ability to capture that image captures two things: the picture of the foot and then the temperature data. So you're getting a thermal signature from that foot. what our algorithms are doing is essentially taking that information and calculating the differences. So you're basically translating that into what is clinically important. So if this can be shown, here's an example of one of the images that we took that shows a localized area of heat. So this is a thermal signature, which may, so that may be hard to see with this particular screen.
Yeah, no, we can see it. We see a little bit of red on one of the feet, and it
yeah,
ice blue on the other.
Exactly. So there's a couple of different ways that we show this information, but one of them is initially you're looking for symmetry between the right and the left foot. And when there is asymmetry, then the idea is it clinically meaningful? So we have other views that help you see if there are anomalies. Now, just like every other company do it, looking at temperature, we understand the thresholds. You have 2.2 degrees centigrade or 4 degrees Fahrenheit. Any difference between the right and left, that's clinically meaningful. So being able to immediately show that in a clinical environment is where we are.
Yeah, that's fantastic. And so it's just an off-the-shelf camera that you've embedded sensors or?
Yeah, the camera is highly sensitive at temperature differences. So what we've done is when I started the company, it was to automate and digitize clinical best practices. The ability to now plug into that sensors that can augment the clinical inspection was really a breakthrough for us. And we spent a lot of time in R&D really fine-tuning how those imaging algorithms work. So now using an off-the-shelf camera that has the specs that are perfect for what we want to look for in the diabetic foot, we've built an automated auto documenting system that allows clinicians to do what they want to do, and that is pick up on risk. And so it's one of the only ways to when you have a patient in that environment to you don't have to send them out for diagnostics. And we're not a diagnostic, but we do provide that clinical insight immediately at the point of care.
And what's incredible is we have so many innovators now that are looking at this problem and trying to solve it. And what's really good is that everyone has different form factors, right?
Right.
And are approaching it in a different way because different clinicians have different habits, different preferences, whether it's a mat, whether it's a camera and using their phone, or even at home. A patient might not use a mat, but they might use a camera and vice versa. So the whole goal here is, how do we improve the quality of life of these patients and save not only life and limb, but also money down the road? It's costing our healthcare system billions of dollars.
Absolutely. No, absolutely. And I think that's part of the awareness. When we talk about awareness, there's two sides. It's the awareness of the patient, understanding, know your risk, know your risk factors, know what your daily healthy habits are to keep your feet well. And know who the people are in your neighborhood. Do you need to be at a podiatrist? Do you need to be, who's going to be helping you keep track of your feet? We are like some of the other companies, the form factors matter. So the preferences for your patient, I think that providers and clinicians who understand their patients so as well as they do will be able to navigate that with them and really help them figure out, is it realistic that they're going to be able to use a mat at home? Is that what makes sense to them? Is it realistic that they're going to wear the socks, or is it realistic that they're going to, want to see their temperature all day long in one particular shoe? Are they going to be able to handle the way that we do it in a non-contact way? We've tested that out. One of the things that we look for is, because it's a non-contact way, it's not just about patients that are in the pre-wound state, but anybody that has an active wound, you want to be able to also look at the thermal signatures of the peri-wound. So picking up on the types of information that helps us know, is there a complication happening? Is there an acute or active Charcot event happening? Again, objectively capturing temperature patterns and thermally mapping them onto the patient's feet have been helpful to the clinicians as well as to the patient's awareness.
Thank you so much, Adrianna Cantu. She is the founder and CEO of Revealix.